ask anyone who's willing to join to please hold their questions until then. We can also assist with any technical support issues you may have if you wanted to send a chat message to us.
Thank you, Gwen. So I think the format of this presentation will be, I'm going to give a brief introduction for a couple of minutes, then Rich will deliver his Grand Rounds presentation. That should take about 45 minutes, and then we'll do maybe a 15-minute Q&A if the questions exist. Okay. Thank you all so much for attending this presentation. This is the first, hopefully one of many to come in the future, of Ethos Primary Care Grand Rounds presentation. So these presentations grow out of our lifestyle medicine rotation. I see Dr. Fuhrman has joined us. Welcome, Dr. Fuhrman.
Hey, how are you?
So we have what about as of 3 years ago, our lifestyle medicine rotation was approved by Rutgers, New Jersey Medical School as part of their education program for senior medical students who are going on electives. I've served at Rutgers, New Jersey Medical School, which is my alma mater, for about 20 years as a community practice assistant professor. And so these students come to our farm, Ethos Farm, and it's more than just spending time in the room with the patients. And we do have quite an interesting variety of different kinds of patients, everyone from children to elderly, to all manner of chronic diseases. So they spend part of their days in patient care here on the farm in our medical practice. And then they also spend time learning coaching techniques, and they also spend time actually on the farm, and they learn about the importance of a regenerative food system and agriculture's crucial links to the health of people and the health of the world around us. This program is directed by Asha Gala, who is our lifestyle clinical director and my right arm. And she really makes it all possible. So we had the great fortune this month of having Rich Wolferz rotate for the month of March. And let me tell you a little bit about Rich. He's a Jersey boy. He grew up in rural Bethlehem Township in Hunterdon County, not far from here. He was raised there. He is now graduating from Rutgers, New Jersey Medical School as a Gold Humanism Honors student. And that with that distinction, his class members have awarded him because of his high level of compassion and humanism and bedside manner when dealing with patients. He also has served until this past month as the vice president of the ACLM,
Trainees.
Yes, Trainees Committee. I knew it was something with training wheels. Trainees Committee. And he intends to go to the University of Utah for his family practice residency. That will be starting in June. Perhaps a love of skiing has something to do with that choice. But perhaps more than skiing, Rich is a runner. He loves running. He has run 16 marathons. And to date, his best personal time is 2 hours, 48 minutes, and 21 seconds. He runs like the wind. I asked him for a quote, and he said this about running. Quote, "Running has the ability to heal you physically,
Well, thank you so much, Dr. Weiss, for that introduction. It was truly an honor to work with you and have the opportunity to come to Ethos Primary Care. And it's been an honor to work in the field of lifestyle medicine and to work with ACLM and all the really just amazing, fantastic, intelligent, passionate people I get to meet and interact with, and hopefully we'll continue to do so. I know it's easy at my age to be inspired and passionate and have a ton of energy, but it's really wonderful to see the people who have been in the field for so long who still have that kind of vigor and are so passionate and excited about where this world is going in medicine. So thank you, Dr. Weiss, and thank you to everyone who's here, and hopefully this presentation is both educational but also enjoyable at this time. It's wonderful that we get to all come together here and share some time. So as all formal presentations start, I do want to talk about my financial disclosures, which since I've been an MD for all of 48 hours, I have none. But I'm always open to them since I do have brand new medical student debt that will soon be collected. So if anyone has ideas. I know Dr. Weiss already kind of spoke about this, but Ethos Primary Care Plant-Based Nutrition Elective, which is what it's called here at Rutgers, New Jersey Medical School, is really one of the...
You do? Good. All right. Thank you. Bye-bye.
Yeah. I'm going to... Hold on. Let me just mute if I can. But yes, the elective for me was 4 weeks. It can be longer. Some people can do longer rotations over the summer months. I know we've had a student from NGMS some years ago who spent, I believe, 6 months on the farm, or even a whole year on the farm before. But it really is a fantastic opportunity for medical students and other college students in healthcare fields to come and really see how lifestyle medicine can be implemented in primary care. So I recommend everyone to reach out to Dr. Weiss, to Asha, to Ethos Primary Care to set that up. An overview of my presentation that I'll be doing is looking into atherosclerosis and some of these other players in the game. So I kind of went back to kind of first year of medical school and really looked at some of the biochemistry and some of the roles that these other players, now that I saw Dr. Weiss getting some of these labs, why are we looking at them and what role do they really play in atherosclerosis and atherogenesis? So hopefully biochemistry doesn't bore anyone too much. I'll try to make it exciting and interesting. But we're mainly going to talk about atherogenesis, the role that oxidized LDL. Yep.
There's a typing noise. Maybe whoever's typing, if we can, or Gwen, if we can mute that.
Yeah. Here, I can mute. There we go. Okay. Let's see if that works.
Go ahead. I'm sorry.
No, absolutely. So, in addition to...
I just want to say hello.
Okay. We're going to also talk about homocysteine and the role elevated homocysteine can play in atherosclerosis, and then what physical activity, the role physical activity can play in counteracting some of the atherogenic processes going on. So why are we talking about this? We're talking about cardiovascular disease because it's the leading killer in the US and worldwide, with 500,000 Americans dying each year, or more than 500,000 Americans at this point dying due to cardiovascular disease, which we now know is mostly preventable. Most of these deaths are preventable disease. And when you think of cardiovascular disease, we think of 4 major areas that we're concerned about: coronary heart disease, cerebrovascular disease, peripheral artery disease, and then atherosclerosis in the aorta and abdominal aortic aneurysms. But all of these really come down to this term atherosclerosis that can be causing things like your heart attacks and your angina, your strokes and your TIAs, your claudication that people are getting. So what do we talk about when we talk about atherogenesis and atherosclerosis? What does that mean? And I love to say that words are important. There's a reason it's called this. So sclerosis, we know, is hardening. These come from ancient Greek, where some of our great physicians started. So we have hardening of arteries. And they're hardened due to this atheromatous plaque, this athera, which in ancient Greek means a gruel. And that's really what it is. It is fat. It is cholesterol that is building up there. So you have this gruel that is building up in your arteries, in the intima. And classically, we've thought of this as this progressive accumulation of cholesterol. It builds up in the intima of middle and large arteries, right? And it's a process that begins very early in life, actually before life. We've now learned, and there have been documented cases where, unfortunately, babies who do not make it to term, when you look into some of their arteries in their abdominal aorta, you see some of these fatty streaks that we thought you had to first be alive and be eating things and eating fats and cholesterols to develop. But this can actually happen even before we're born. But it was believed like, oh, this is just a process. This is natural. This is what happens. It's inevitable, right? Unavoidable. As you get older, you're just going to keep building up some of this cholesterol in the walls of arteries. And this is what happens. But we know there has to be an insult somewhere to start it. Often it was thought that it's just unknown. We're not exactly sure what causes the damage or why it first starts, but then you get this buildup of cholesterol that begins. But all of us are lifestyle medicine practitioners, or in the world of lifestyle medicine. We know that these causes aren't unknown of what damages the endothelial layer in arteries. It's things like hypertension, right? When high blood pressure over days and weeks and months and years is pushing on the walls of these arteries, it's damaging that endothelial cells, right? Things like smoking, where you have toxins coming into the bloodstream, dietary toxins, fatty acids, cholesterol, high levels of cholesterol, homocysteine that we'll talk about, right? TMAO and polycystic aromatic hydrocarbons, and inflammation and chronic disease. All of these things create an environment inside the blood vessels that are harming the endothelial lining, right? And allow then for damage and opening that cholesterol can get inside. And so after that initial insult, you end up with this buildup of LDL and cholesterol developing into these plaques. And as these plaques grow, they become unstable as they become larger and larger. And once they become unstable enough and you have the pressure of the blood flowing past, they can rupture, right? And this rupturing puts out thrombogenic material into the artery and quickly clots up and creates that blood clot that becomes your myocardial infarction, your heart attack, becomes your stroke, right? But this seems really scary, right? And we know that our bodies develop mechanisms to work on this. And that's where we've learned that atherogenesis isn't just progressive, unavoidable, just happenstance of cholesterol building up in the arteries, but it's really an inflammatory process because our body's immune system is going to come in and try to circumvent that, right? It sees that some damage has been happening to the endothelial lining. The endothelial cells are able to release cytokines and recruit monocytes that become macrophages from the immune system and other immune cells to come in and try to repair it and try to get rid of that cholesterol that's starting to build up. As those macrophages try to eat up that cholesterol and then transfer it over into some of the lipoproteins to get rid of it. Right? And we now are realizing that this immune reaction and this inflammatory process, yes, it's there to try to help and correct, but it also fuels atherogenesis and atherosclerosis because as those cells come in and those macrophages come in, they increase the size of that plaque as these inflammatory cells come in. And at the same time, you have inflammatory molecules, reactive oxygen species, myeloperoxidases that are in there that are making this worse, right? And compound on the initial insult and that buildup of LDL. So I want to just step back real quick and talk about lipid metabolism, a little bit about cholesterol. Because we also learn in medical school, in undergrad, and high school, that cholesterol isn't always a bad thing. We need cholesterol. It's in our body. It makes up membranes of cells. It makes up hormones. So you would think then our body has some mechanisms of dealing with cholesterol in a good way, right? And we do. We have lipoproteins, which I alluded to before, these low-density lipoproteins, these high-density lipoproteins. And lipoproteins allow for cholesterol to be transported around the body because cholesterol does not do so well in that aqueous environment. But when you have the lipoproteins, they're able to increase the solubility and move that around. And you have your LDL that does the forward transport of cholesterol from the liver and sends it out to cells that need it, that need more cholesterol to build their membranes, to build their hormones, right? And then you have reverse cholesterol transport, which is your high-density lipoprotein, that it goes out at first without any of the cholesterol of the chylomicron esters in it and goes to cells who are attracted over and reuptakes that cholesterol and then brings it back and cycles it back to the liver so that the liver can process it or excrete it, right? So that all sounds good, right? So why then is this cholesterol becoming a problem? Why is atherosclerosis an issue? Why are we having heart attacks, right? Well, there's more to it. There's other homeostatic mechanisms in that cholesterol delivery to try to keep it in balance as well, right? So you have LDL receptors that are on endothelial cells, that are on peripheral cells throughout the body, that are on these macrophages, that help draw in the LDL cholesterol when they need more of it, right? And that's what macrophages use when they go to try to clean up this atherosclerotic plaque that's developing, right? They go in there and through the LDL receptor are able to take up the LDL molecules that are in the intima of these arteries, right? But then once these macrophages take all they can and become full, they're able to downregulate that LDL receptor and prevent more LDL from coming in so that they can then go and transfer over that LDL to the HDL molecule, that cholesterol, those chylomicrons, to the HDL molecules, right? And they do that through the ATP binding cassette 1, ABCA1, right? And that is then upregulated by macrophages and other peripheral cells when they want to expel cholesterol and send it back to the liver to be processed. So again, if we have these mechanisms in place, why is this becoming such a problem? That's because it's not that clean and simple. And the LDL doesn't always just stay nice LDL that our body is used to, this native LDL. What happens when the environment is right, or should I say wrong, that LDL, that native LDL, can become oxidized. And that oxidized LDL is really, how I like to say it, a supervillain. It takes on superpowers of normal LDL. We think of LDL as being bad cholesterol to start, but LDL plays a good role in the body and should be there in appropriate levels, right? But oxidized LDL is really the issue because oxidized LDL does not play a good role in the body, right? It takes what LDL is doing and supercharges it because it no longer plays by those rules, those homeostatic mechanisms that our body has, right? And how does LDL get there and become oxidized? Well, it's a chemically reactive process, and you have an oxidative environment, right? And that oxidative environment we've known fuels atherogenesis. Things like diabetes, kidney failure, infections, diets rich in saturated fatty acids, right? All of these things can oxidize LDL, right? And create these reactive oxygen species, not even just in LDL, but create free radicals and reactive oxygen species. But they can all work on lipids and lead to this oxidized lipid environment, right? And convert that LDL into this supervillain LDL. And why do I call it a supervillain? Because what oxidized LDL is able to do, right? Oxidized LDL, now when it interacts with those endothelial cells in our vasculature, it disrupts that ability to induce that ATP binding cassette 1, which is that receptor and interactor with the HDL that allows to unload the cholesterol that has been built up there, right? it blocks that from happening. It says, no, I want to stay here because the oxidized LDL wants to build up there, right? It doesn't want to get taken away and recycled back to the liver. And at the same time, it increases the production of interleukins and cytokines by those endothelial cells to attract more inflammatory molecules, to attract more of those monocytes to become macrophages. And in a way, it's a parasite, right? Because once those monocytes and macrophages come over, whose job it is to take up that LDL, right? And to process it and help recycle it back. What that oxidized LDL does is once it gets in there, similar to on the endothelial cells, it helps deregulate that ATP binding cassette 1 because it doesn't want to leave. So then it packs full that macrophage until the macrophage is now full of oxidized LDL that it cannot get rid of. But beyond that, that oxidized LDL goes a further step. And as that macrophage downregulates its LDL receptor and says, I'm full, I cannot take any more LDL, that oxidized LDL on the outside uses these scavenger receptors. It doesn't need to use the LDL receptor anymore. It goes over to the scavenger receptor and uses that to load itself into this macrophage. And it begins to overfill the macrophage. So the macrophage now gets so filled with LDL and oxidized LDL that it becomes a foam cell. And here's that foam cell formation we talked about. And that's what you hear in these plaques is this foam cell accumulation that really starts to build the size of these plaques once you get into that dangerous zone where the plaque starts filling up more and more of that artery, right? And you would think with these homeostatic mechanisms that those foam cells would not form. It wouldn't make sense why a macrophage would do that, because when it fills up that much with cholesterol, it's not able to act as a cell anymore and do its job. It cannot move around. It is so filled. And it's because oxidized LDL is circumventing those homeostatic mechanisms and taking over that cell for its own goal. And then within the plaque, as that plaque grows and grows with these foam cells and with more and more oxidized LDL and LDL packed in there, those cells are not able to operate because there's so much fat and cholesterol around them. And they're now getting farther and farther from the lumen of the artery. Diffusion is no longer working. They're not getting oxygen and the other metabolites they need to survive. And the macrophages and smooth muscle cells begin to die at the center of that plaque. And as those cells die in the center, you now have this large and growing plaque with a hollow core, and it destabilizes further and really puts you at risk of rupture. So now when we go back to this diagram before, that looks like a lot is happening, you can start to see those LDL and oxidized LDL, and as those fill in, and you see these macrophages turning into these foam cells packing in this plaque. And the necrotic core of that, leading to your thrombogenic event. But I want to transition now to another actor here. And you'll see it marked off right here. These little gray pentagons, which are marked as homocysteine. Now, homocysteine, let's see if we can think back to what do we know about homocysteine, right? So thinking back, homocysteine is obviously a non-coding sulfhydryl-containing amino acid, as we all remember from biochemistry. But what does that mean? So it's non-coding because it's not used to create proteins, right? It instead works as this intermediary in these metabolic processes, right? It works in the metabolism, methionine from the diet, and it's sulfhydryl-containing. It has this sulfur group, this sulfhydryl group here, which we know sulfur groups and sulfhydryl groups are often reactive, but it's more just an intermediary from methionine. It works in these sulfuration, in these methylation pathways, right? So as methionine from the diet is taken in, it's acted on by these methyltransferases that help in all these different biochemical and biometabolic pathways where you need to move around these methyl groups. And homocysteine is that one of those intermediary steps. And then, as we remember, there are some important cofactors that we can remember from this step. And this is where your vitamin B12 and your vitamin B6 and your folate all come into play, and why they're important. Because a lot of these enzymes, these methyltransferases, require some of these cofactors. And when you're missing some of these cofactors is when you can start having breakdown of this process, right? And also when you have some of these enzymes not functioning properly, you have breakdown. And that's what a lot of us remember homocysteine as. Is this condition homocysteinuria, which there are some children who unfortunately are born without sufficient methyltransferase and some of these other enzymes in this process. And as such, homocysteine ends up building up in their body. And we know that the homocysteine just builds up and collects everywhere and leads to a lot of developmental issues for these children. But something that is really interesting is what was found also in these children, which was atherosclerotic plaques. And this is what started people thinking, does homocysteine play a role in atherogenesis? Because why would young children, these children with these diseases and mutations in their methyltransferases, in these metabolic pathways of methionine metabolism, why would these children end up with atherosclerotic plaques? And here's where you get the homocysteine theory, right? Where metabolic and nutritional factors lead to this hyperhomocysteinemia. And this hyperhomocysteinemia does something where plays some role in either damaging the intima or intensifying the atherosclerosis that's going on. And we then know when we go to population studies, such as the Hordaland study, which is done in Western Norway in the 90s, looking at tens of thousands of adults in this country, that we can connect high levels of homocysteine in the plasma with all-cause mortality, with cardiovascular events and hospitalizations, but even things like poor pregnancy outcomes and lower bone density. And in a review of atherogenesis by Chernovsky, they looked at hyperhomocysteinemia and how it could, on the metabolic, on the biochemical level, how it could contribute to atherogenesis and cardiovascular disease. And what they were able to find is this homocysteine, and especially high levels of homocysteine in the plasma, is actually quite oxidative and increases oxidative stress and the formation of reactive oxygen species. And some of that has to do with that sulfhydryl group I talked about, and it being converted over into sulfates, and it reacting and adding to this oxidative environment. In addition, though, that homocysteine has been connected and postulated with altered vascular responses in endothelial injury, and even stiffening the artery on its own, and leading to vasoconstriction, which can increase, and it's been connected that homocysteine, high levels of homocysteine, is correlated with hypertension. Right? There's also, with unclear mechanisms, connection with enhanced plaque rupture with people with high level of homocysteine, and increased inflammation, which we've talked about, and cell adhesion of those macrophage and inflammatory cells that come in to try to help deal with that insult and that atherogenesis that's going on. So when we go back to the Hordaland study, and we look at, not only in this study of these adults in Norway, did they look at homocysteine levels, but they also took lifestyle questionnaires of them to try to see what they could connect. So when you look at higher levels of homocysteine, what does it associate with? And you might notice something very similar here to what we know. Increased age, the male sex, smoking, high blood pressure, unfavorable lipid panels, high creatinine. These are all risk factors in what we see with people who have cardiovascular disease. Right? And I know you see coffee consumption there as well. And that one is very interesting and a little bit off subject here. And there's some decent research of trying to understand that. And it seems to do with some of the diterpenoid alcohols in coffee, not the caffeine itself, but some of these other alcohols that have been known to increase things like LDL in unfiltered coffee that might be playing a role with serum homocysteine. But I'm going to leave that aside right now and focus on the other that we know are risk factors of cardiovascular disease. But then we also want to look at what things were connected with lower levels and associated with lower levels of total homocysteine and plasma homocysteine. And especially those were physical activity, right? And plasma folate and vitamin B12. And that's where the folate and B12 makes a lot of sense, because that goes right into the homocysteine pathway, where it can be the converted back up to methionine, where you need folate and vitamin B12, or you can convert it
His
down
voice is fucking annoying you.
to cysteine, and then off from there back to succinyl-CoA and recycled through the carboxylic acid cycle, right? But what was really interesting is in that Hordaland study and in the paper that was published with it, the authors mentioned that solely a change in lifestyle may have a stronger effect at lowering homocysteine than even high-dose folic acid and some of these other interventions. So it's not just a drug, but they're saying these other activities of avoiding smoking, avoiding alcohol, being a healthy weight, and managing your blood pressure and being physically active would be important there. But could homocysteine, should we be looking at it? Is it a marker, and what role does it really play? And I wish I had a very clear answer for you, and I wish the research I did had a very clear answer. We know it's connected and involved, and it plays a role. And it's something that if we do look at, and you find it early and it is elevated, it should be a red flag and a concern and something you address, because that person your patient is much more likely to have cardiovascular disease at a later date than someone who has low normal levels of homocysteine. But we really don't understand, is it a chicken or an egg idea of homocysteine? Is homocysteine the aggravator, or is it just some risk, or does it come about as part of this inflammatory process, right? And there have been some studies and interventions where they tried to lower homocysteine levels by giving dietary antioxidants. And those don't always seem to change the outcomes in cardiovascular risk. It doesn't prevent people from having cardiovascular events by just altering the homocysteine through antioxidants alone and bringing that down. But I do think it is something that we need to research more and study more and be aware of and understand that it does play a role and does really accelerate this atherogenesis and atherosclerosis. And there's one more actor here I want to talk about, and it's peroxygenases. And because I wanted to give you a good player here, a superhero, not just some villains that we want to talk about. Because peroxygenases are proteins that are on HDL, associated with HDL, and they really help protect against some of this lipid oxidation, right? They can actually prevent the formation of some of the oxidized LDL and even work to as an antioxidant enzymatic activity against the oxidized LDL and stop some of the reactive oxygen species that are there and help stimulate cholesterol efflux from macrophages to prevent them from becoming foam cells. So what I'm going to do now is move to what physical activity and the role of exercise can play in all of this, as I give you that background to show you that atherogenesis isn't solely just a very simple process of cholesterol building up. There are a lot of metabolic and biochemical pathways at play here. And as Dr. Weiss mentioned, I will say I am an athlete. I enjoy staying physically active. And not to toot my own horn, but it's a fun fact here that I did graduate this past week and was voted with my good friend and fellow lifestyle medicine interest group leader, Nicole, as most athletic in our superlatives for our class. So physical activity means a lot to me, obviously, but it also means a lot to me as a physician and as a clinician, and something I want to talk to my patients about. Because physical activity, and I use them slightly interchangeably, exercise and physical activity, but I really do like the term physical activity a little bit more because it doesn't have to be exercise, and exercise for some people is not their cup of tea. And that's okay, because I would rather you go out and just be active all day long than sign up for a gym membership and have to go there and get on a treadmill every day. And I want everyone to find their own path of physical activity and just stay active. And why do I want that? And why do I recommend that? Is because the physiological benefits is similar to a multi-drug approach, especially for things like cardiovascular disease, which exercise is extremely good at dealing with as well. But it doesn't have these side effects, and the side effects it does have are often very good side effects. Because one of the greatest benefits of physical activity, not only does it make you just feel better, allow you to move easier, it strengthens your muscles, but strengthen your bones and help fight against bone density loss. It has mental and psychosocial benefits. And it's one of our most powerful tools against things like anxiety and depression. And we know how powerful it can be to step outside and go for that walk, go for that run, and meet up with friends and do that. So that's why it's so important. But it's more than just that. Physical activity really is powerful because it provides an acute stress that leads to protective adaptations in the body. So I want to bring this up here because in my search, I went to UpToDate, as most young physicians are taught and medical students are taught, and looked at atherosclerosis and some of these oxidized LDL, and they had a potential strategy for preventing the development of atherosclerosis before I talk about my own. And theirs was something very interesting that I'm sure we all know well. Recombinant adenovirus-mediated gene transfer at decoy macrophage scavenger receptors could block some of these foam cell formations. That seems like a really good potential strategy. But I'm going to present you and leave that for another expert to talk about. Something in the world of lifestyle medicine that is not just a potential strategy, but really a known strategy at preventing, treating, and reversing atherosclerosis, and that's plants and physical activity. And to me, that's a little bit easier to design than some recombinant adenovirus-mediated gene transfer. So let's go through and look at all the benefits and the different things that exercise and physical activity work on. So when we look at the coronary arteries, since we were talking a lot about coronary artery disease and really concerned about keeping our coronary arteries patent and open and blood flowing through them, exercise and physical activity has been shown to have a restorative effect on coronary arteries that we know as they age, the lumen begins to shrink and the arteries begin to stiffen. And exercise can help prevent that and increase that luminal space and reduce the collagen to elastin ratio, increasing the elastic potential as the arteries need to adapt and learn. Because when we exercise, our blood pressure has to raise. We need to move more blood around. We need to get more blood to our heart. They need to be elastic, but then they need to come back down after the exercise, which is where some of the magic occurs as well. It's not just the time you're exercising, but it's the time after, as your body cools back down and as those arteries are able to shrink back down to accommodate now your rested state. And if we look in a spontaneous hypertension rat model where a lot of these studies come from, exercising rats had 40% more coronary artery elastin than the sedentary group. But not just that, exercise was shown to reverse and prevent the elastin depletion from aging when you looked at the aging in the sedentary rats versus the exercising ones. And that exercising was able to normalize elastin, collagen, and smooth muscle balance within the aortas of these rats, even as they aged. So now if we look at the plaque health, since we're talking so much about atherosclerosis, can exercise help with that? Right? Because you would think exercise, again, increases our heart rate and our blood pressure. Does that put us at risk? Should we be telling all our patients who have atherosclerosis or any cardiovascular disease, stop, don't exercise, sit down? No. No, we should tell them to move. And yes, maybe it looks a little bit different and you're not going to give them free rein right away, depending on the severity of the disease, but exercise is important and physical activity is still important in these patients. And it's powerful because it helps regulate the plaque size and rupture potential by actually working, again, on modulating with collagen and elastin, modulating that matrix formation and solidifying that plaque and that fibrous cap around the plaque to decrease the chance of it rupturing. But also even just decreasing the plaque size. And it also does that through reducing foam cell formation, enhancing reverse cholesterol transport, and elevated LDL levels to pull back some of that cholesterol and get rid of it and reduce that size. And when we look at dyslipidemia, significantly reduces triglyceride levels and decreases total cholesterol. And yes, some of that is through just being up and moving. You're able to burn some of that fat and those triglycerides that are in the blood, and you're able to pull them back as your body needs more energy sources. But in addition to that, when you have studies of 8 weeks of low intensity walking, this is 10,000 steps per day, 3 days a week for 8 weeks, right? Not even meeting some recommendations of physical activity. But even that was shown to increase LDL and this liver X receptor alpha, which is a key regulator of some macrophage function and controls some of the transcriptional programming in lipid homeostasis and inflammation. Right? And through those mechanisms, you see that, excuse me, through exercise, you do see some increased oxidative stress in the acute phase. But in the long term, you see these good adaptations of increased HDL and this liver X receptor alpha to enhance reverse cholesterol transport. And you even see sometimes increased oxidized LDL levels, both after the acute phase and even in these 8 weeks trials. Over those 8 weeks, you see some increased oxidized LDL. But it's not just me who interprets this way. Even the authors talk about how, of these studies, that they believe this is the body reclaiming some of that oxidized LDL and trying to bring it back and recycle it and allowing the liver to excrete that. And now if we look at this Frontiers of Physiology review from 2018, when you look at athletes, cyclists, and runners, they present with greater response in the reverse cholesterol transport pathway when compared to the sedentary peers. And it's done again through some of these other mechanisms and some of these other actors we talked about. As exercise is able to upregulate that ATP binding cassette A1, right, which allows macrophages to deload some of that cholesterol and give it over to HDL to bring it back to the liver, right, and improves HDL recovery of cholesterol. In addition, it increases concentrations of ApoA1, which is the main protein component in HDL proteins and high-density lipoproteins, right? So not only are you allowing those HDL molecules to take back more of that cholesterol, but you're allowing more of the HDL as well through exercise. And then it also counters oxidative stress. And I know I just told you that exercise creates oxidative stress acutely. And this is something I love about exercise. And it's something I personally enjoy about it, because exercise and physical activity are difficult in the acute phase, right? And they create oxidative stress, and they're tough on the body, and they can break you down and make you sore. And even on the biochemical level, they're creating reactive oxygen species when you're breathing in a lot of oxygen, right? And you're trying to make as much ATP as you can for your muscles. But when you do that day in and day out, in the proper dose, you're teaching your body to deal with those stressors. And that's what our body is. Our body is not some fragile being that we need to try to protect and put in a bubble. We're meant to live in this beautiful planet we're on and live by moving and eating and interacting with others. And in doing so, we expose ourselves to some risks. But by doing that, we strengthen ourselves, right? We see it, it's easy to think in the immune system. Obviously, in the immune system, we know if you never expose immune cells and immune system to any pathogens, it doesn't know how to then protect the body from those exogenous external pathogens. And instead it turns in and starts fighting itself because it doesn't know what else to do, right? And similarly, our body, with things like exercise, with this oxidative stress, we need to allow it to practice, right? And by doing this in these bouts of oxidative stress, that it can strengthen these mechanisms, so that when you have large doses of oxidative stress, it knows what to do with them. So when we look at things like the peroxidase enzymes that I talked about before, those PON1, heavy exercise increases that PON1, that superhero antioxidant, that's able to go in there and attack the reactive oxygen species and to try to deoxify LDL and to try to enhance the expulsion of cholesterol from these macrophages. And heavy exercise increases that PON1 both in physically active and sedentary individuals. But the real magic is when you look at single bouts of moderate exercise, where those peroxidase enzymes are really only increased in individuals who have been active. Because their bodies have adapted, right? So that they know what to expect. So even when a little bit of exercise, when you get a little bit of this buildup, they go on right away. They turn right on, like, okay, I see what this is. I see those reactive oxygen species, these oxidation molecules. I'm going to go and address that right away, right? It's the people who are not doing that on a regular basis, whose systems aren't primed, whose natural antioxidant systems are not primed to deal with these oxidative stress, that instead it builds up, and they need a large bout for it to finally activate. So we want to really encourage our patients and ourselves to exercise regularly and make this part of our day, because we want our bodies to be primed and ready when any small insult comes. Because if we're going to address that insult in the beginning, going all the way back to what I started about, that initial insult in the endothelium, right? That reactive oxygen species that damages it, we want our body to address that right away and not allow that to stay open, to then allow LDL and then more oxidative processes to go on to make that oxidized LDL and start building up this plaque. We want our bodies to be ready to address that right away, right? Additionally, exercise and physical activity has been shown to reduce that superoxide production in the arterial wall, right? Reduce likelihood of oxidized LDL formation, reduced likelihood of superoxide being able to damage the intima and damage our arteries and vasculature. That's why regular exercise is so important. And now, what if we look at homocysteine? Can exercise and physical activity play a role there? So when we look at a mouse model here where they took mice and they restricted their dietary folate, we saw a 2-fold increase in plasma homocysteine, which we'd expect, right? We know that folate is necessary to be able to recycle homocysteine back to methionine. So we expected that, and that's why they did this. That's why they restricted their folate, to create this mouse model with high levels of homocysteine. But then they took the group and allowed some free access to their running wheel exercise, and others were kept sedentary. It wasn't even like they were forcing them to exercise. It was just free access. And we know that mice who are just let free want to exercise just like all mammals and animals and humans want to. When we're feeling good, we want to get up and move around. And those mice that were able and had access to move around, even with their high homocysteine, their free access to exercise completely negated that homocysteine increase. So that 2-fold increase in plasma homocysteine that was seen in sedentary mice that had the dietary folate restriction was not seen in those that could exercise, even though they did not have the folate. So that means they had to get rid of the homocysteine in other ways, right? But not only that, exercise reduced homocysteine in the control diet group. They had mice that they did not restrict the folate from, whose homocysteine also went down by 36% exercising compared to their sedentary counterparts on a controlled diet as well. And what was found was an enhancement in kidney levels of this betaine homocysteine S methyltransferase, which I know is a mouthful, but it's another mechanism of your body's ability to excrete and deal with this high levels of homocysteine that was enhanced in these mice who were able to exercise. I do want to note, though, that in some of these mouse models, they also found that hyperhomocysteinemia can actually limit exercise capacity. And again, there's a lot in homocysteine that we don't fully understand its role. But what it's saying here is it was showing decreased ATP levels and mitochondrial transcription in muscle tissue in some of these mice with high levels of homocysteine. And what they recommended is that making sure you're trying to correct hyperhomocysteine to realize full exercise benefits. And what that really means to me is avoid hyperhomocysteine. We got to prevent this from happening, which is why it's so important to do the right things and have our patients exercising and eating a good diet, high in folate, making sure they're getting their proper B vitamins from a really plentiful plant-based diet. In addition, just like exercise does a lot of odd things, increasing oxidized LDL, it increases homocysteine in that acute phase. In studies of runners after a marathon, it was shown to increase their homocysteine significantly compared to baseline. But you also have studies that show long-term daily exercise can lower that plasma homocysteine level. Right? Again, because exercise teaches our body, it puts it through some stress and teaches it and allows it to learn and strengthen, so that in the long term, it can be healthier and it can be ready to deal with some of those stressful, oxidative, and damaging processes. So now what can physical activity and exercise do on our macrophages and our endothelial cells? And it actually has an anti-inflammatory function. And it encouraged the macrophage when those macrophages can differentiate into their M1, which is very pro-inflammatory version, or their M2 differentiation, which is very anti-inflammatory with their IL-10 and your TGF beta 1, their VEGF in there. That is what exercise and physical activity does. It increases more of these anti-inflammatory, because again, your body needs to deal with that acute stress, and it does that by recruiting these anti-inflammatory, antioxidant pathways. And having those anti-inflammatory macrophages around, you help preserve endothelial function. And it actually reduces monocyte adhesion and chemotaxis, which in the sense of when we go back, seeing atherosclerosis as really this inflammatory and immune process. When you can stop some of those monocytes of going in there and making it worse, and instead allowing anti-inflammatory ones to come around and collect and try to let that reactive environment calm down, that's what we want to be able to do, and that's what exercise allows us to do. So what should some of these recommendations be? And I know a lot of my presentation has really been in the weeds and biochemically and looking at different receptors and pathways, but I want us to be able to step back and remember that there is some takeaways here and why some of this is important and why we want to look at this. So when it comes to exercise and physical activity, we can look at groups like the American Heart Association, the American College of Sports Medicine, and they agree and recommend on at least 30 minutes of moderate intensity physical activity 5 days per week, which goes back to exactly what I was saying of the research that backs this up, showing that this regular, moderate physical activity really primes the body and strengthens all these antioxidant and anti-inflammatory pathways in the body. They also recommend 20 minutes of vigorous aerobic exercise 3 days a week. And that vigorous activity really gives some of the strong benefits because it actually creates really stressful environment for your body. But when done in the appropriate doses, the body can get stronger from that, right? And then 2 to 3 days per week of resistance, flexibility, and neuromotor exercises. And I know I didn't get into all the research, but I promise you it is there when looking at oxidized LDL, when looking at homocysteine, when looking at cardiovascular disease, that it's not just cardiovascular exercise, not just aerobic exercise, but even resistance training and strength training has and offers some of these benefits as well. So as clinicians, what can we do? And this is a paper by Verghese et al. Talking about physical activity and the prevention of coronary heart disease. And what are their recommendations in urging us as clinicians to remember to view exercise and physical activity and the quantity of that as a vital sign. And this is a vital sign for our patients, that we should be documenting this, just like you're documenting their weight and their height and their heart rate and their blood pressure, but how much they're moving every day and every week. And prescribing physical activity like it is a medication, because it is. It is one of the best medicines we have out there, and we should treat it as such so that our patients respect it as such. And then they also encourage using technology to encourage a global shift in focus from cardiovascular disease treatment to real prevention and addressing it at the root cause with things like diet and with exercise. And that's where you get models like active model, which is when this is the idea of exercise is medicine and how we treat it as such, of assessing your patient and making sure that exercise recommendations are personalized, just like every medication and dosage is personalized to that patient and their disease and their situation, and creating that individualized plan and tracking progress. And unlike other medications we might deal with, this is a medication we want to continue to increase. We want to increase physical activity and exercise as your patients grow and grow stronger, because more is better, right? And validate every time you see the patient, validate their efforts of they're doing every time they get out there. And even if they're not meeting the dose you want yet, every little bit counts, and encourage them. And remember to empower them and allow them to self-select. And that's why I love the term physical activity. Because to me, my physical activity, when I choose, is often running. And running for many people is seen as exercise and seen as painful and not enjoyable. And I don't want to just go out there and prescribe that to people, but I want to empower the patient and really understand what they like to do and what brings joy in their life of being active. And maybe that's getting out and gardening and going for a walk with their spouse, or playing with their grandchildren, or going dancing. All of this movement is good, all of it. So we can let go of, it's not just exercise, but real physical activity, just staying moving. So in conclusion, we reviewed atherosclerosis and atherogenesis as an inflammatory process that can be countered by the anti-inflammatory benefits of physical activity. We discussed the role of oxidized LDL really as a supervillain when it comes to atherogenesis, as it escapes the homeostatic mechanisms and controls and accelerates foam cell formation. We looked at the possible risk of elevated homocysteine and atherosclerosis as a risk factor of cardiovascular disease, as a pro-inflammatory marker, but how we need more research to really understand its role and what we need to do about it when we find patients with high levels of homocysteine. And then I presented the role of physical activity and what it plays in atherosclerosis, being able to treat and prevent it, and understanding the chemical, the metabolic, the physiologic, the structural adaptations that physical activity offers to our body that can help prevent, manage, and reverse atherosclerotic disease pathologies. Some of the work cited, even more, were included in the number of different reviews and meta-analyses. But I do want to thank you guys. I know I ran a little bit over on time, but it really has been an honor. And I hope you enjoyed and found this informative. And if you do have any questions, I'd be glad to hear some questions, and hopefully we can come to some answers or find some room for more investigation on our own and more research that needs to be done. But thank you.
Yes, we'd like to say thank you very much to Dr. Wolferz, and it's been a very informative, eye-opening presentation. We would love for anyone to join in with questions. I do see that Dr. Klaper has written in a question here. Is Dr. Klaper still on the line?
Yes, Dr. Klaper is still on the line. Hi. And very good presentation. That was very insightful. 3 questions that I've written here. We're talking about oxidized cholesterol, and I agree it's a major atherogenic stimulator. And where it comes from, then we're talking about various intracellular factors, etc. But are we overlooking the major source of oxidized cholesterol? And that's the skillet and the barbecue and the broiler. And there's nobody eats raw meat. And the very act of cooking animal muscle must oxidize massive amounts of cholesterol in those cell membranes. And so every burger and chicken and fried chicken wing must bring in just a flood of oxidized cholesterol molecules into the bloodstream, which can't help the endothelial membranes. And should that not be on the list as ingested oxidized cholesterol? Is that not the major source? Is one consideration, and one reason may be that plant eaters have a whole lot less artery disease than the flesh eaters. Second, since it's an inflammatory process, do you think there's a value in measuring inflammatory markers these days? I often order panels with HSCRP, prostaglandin 2s, myeloperoxidase, and phospholipase. Do you think they have a role in management of this disease? And if a patient comes to you with a high calcium score, what does that mean to you?
So thank you so much, Dr. Klaper. Thank you for joining, and thank you for your questions. So I'll answer them in order and to the best of my abilities. And please, anyone else who would like to contribute, the floor is open to that as well. I agree. And I wouldn't say as much that overlooking as just not mentioning here and not really going into all the dietary factors that I agree are probably some of the most powerful. And you were right, when it comes to oxidized LDL, it's not just that our own LDL in our body is be endogenously being oxidized, but we are also consuming oxidized LDL as well. So I 100% agree. And that is, if that is not something you've already worked with your patient, if you have a patient who you're looking at oxidized LDL levels and you're worried about their atherosclerosis, if that's not something you have already addressed with them, that should definitely be the primary thing you're looking at, for sure. But I think it is also important, and that's what I was working with, is that it's not just diet. It's not patients. It's like once you've cleaned that up, they're out of the woods for some of this oxidized LDL as well.
Fair enough. Agreed.
Yes.
Okay.
I strongly agree with that. So being the inflammatory process, yes, I do think there is role in measuring other inflammatory markers as well. With the understanding, again, you need to understand timing for when you're looking at inflammatory markers, especially as someone who just gave a presentation on exercise and reading in acute bouts of exercise, acute exercise is very pro-inflammatory. So I do think they can be very useful, but I think there are other things you have to be careful sometimes because they can falsely, I would say, be a red flag if you don't understand and may not realize what your patient is doing right before they're getting that checked and understand the timing of doing that. But it's no different than timing other labs when it comes to fasting before certain lipid panels that you might be looking at as well. So I think definitely taking that into consideration is important. But yes, we know that things like myeloperoxidase is a strong risk factor when that is elevated for severe and more severe atherosclerotic disease and cardiovascular events in their time. And,
yeah, my understanding of the myeloperoxidase and phospholipase is that at that point, the leukocytes have invaded the plaque, and they are releasing these enzymes that soften the plaque. And if these enzymes are elevated, the chance of plaque rupture are approaching, serious concern there. So I find them useful. If the MPO and the phospholipase is elevated, I'm very concerned about this patient. So that's my viewing of it there. Mm-hmm.
Absolutely. And thank you for bringing that up. I do think that is really important. Another one to mention that I came across a number of times is actually antibodies to things like oxidized LDL have been found as well that you can look at. And those have been correlated with pretty advanced cardiovascular disease, where this is that inflammatory immune response where your body knows this is wrong. This oxidized LDL is not supposed to be there, and it is going to attack it, and it actually produces antibodies to it as well.
If I can make a comment, Rich.
Yes.
As you know, in the month you spend here, we do almost on every single one of these patients, we get these markers.
Yep.
And we have a particular fondness for oxidized LDL. And we routinely see it. All of these markers, I can't remember a person who went from an omnivorous diet to a good plant-based diet where even within a month these markers did not drop substantially, usually a third across the board. The other thing that I find of interest is we do have the occasional patient who is plant-based, Dr. Klaper, and these patients sometimes still have signs of atherosclerotic disease, and they'll come in with an increased calcium score that they got from another physician who got a screening test, and even though they're eating plant-based diets, these few people, if we can still demonstrate in a few of them sometimes very high oxidized LDL levels, and that really prompts us to get very aggressive with them. And I hope that it inspires the patient to pick up their speed and really go to a high level of exercise and eating. And if that still doesn't do it, then I think that may be a basis for starting a statin agent.
Yeah, fair enough. I agree. That's how I handle it too. I'm curious, why would this patient have such a high oxidized cholesterol? Where's it really coming from? And I wonder what this quote plant-based diet really is. And if he's at your institution and really eating pure plants out of the garden, I suspect that the quality of their diet probably wasn't the most friendly.
ASHA analyzes every single meal that they have. And unless they're lying to us, which I guess is not an impossibility, but I don't think it's likely. I think that it can be used selectively in these patients to help weed them out, decide who should go on medication.
Yeah, I agree. Some folks have congenital issues, or I agree. But the very fact when they come to your place and they're literally eating vegetables out of the garden and their markers get better, then you have to assume that their previous diet wasn't up on that level. And so, it just all fits. When you say plant-based diet, that allows a lot of unhealthy foods in there, perhaps. But okay, I don't want to monopolize everybody else's time here.
As far as the third question, thank you. I think all of these are, again, all these markers are really important to track. And I don't believe we have full understanding of all of them as of yet either. And I think that's why we do need more and more research of all these other players in atherosclerosis. It's obviously a very complex progression, and there are a lot of players in there that we could be using as other possible markers. And as far as your third question, what does high calcium score mean to you? High calcium score and the cardiac calcium scores are being used more and more because this calcium is also deposited in these plaques, especially as these plaques grow larger, and can really be a sign of high level severe atherosclerosis and coronary artery disease. So yeah, high calcium score would be very concerning in a patient as well.
Do you think calcified plaques are more likely to rupture and cause thrombus, or less likely?
From what I know, and please correct me, is that they're actually less likely to rupture. They're a more advanced plaque, the calcium being in there to help stabilize the plaque. So that's my understanding, is that they're actually less likely to rupture.
Yeah, I agree. So why is that? Why do high calcium scores concern you then?
Well, I would say they're still concerning because they're showing that there is advanced atherosclerotic disease. Your body's been doing the best to try to secure those plaques. So maybe that patient isn't at acute risk of that plaque rupturing, but they are at risk of having, like, atherosclerosis, as I mentioned in the beginning, doesn't occur in one place. And there are, it's affecting your arteries throughout your body. So high level calcium score means you've had this atherosclerosis progressing over years and decades. So I think it's a patient that really doesn't need a lot to be done in the course of their health. Maybe they're not going to die walking out from that specific plaque rupturing, but I think it is still concerning.
Good, fair enough. Yeah, absolutely. It's a sign of diffuse advanced disease. Yeah, we agree on that. And it's certainly a note of concern. Okay, well done, sir. Well done. Those are all well handled.
Thank you so much, Dr. Klaper.
I think that was fascinating. Dr. Esselstyn.
Thank you, Dr. Esselstyn. It's an honor that you joined in.
No, listen, in these days, I couldn't resist. There's nothing else. Well, I just would, I thought it was interesting that I can remember, I think it was about, over 20 years ago that I must have read a book by Kilman McCulley. Mm-hmm. His whole idea was on homocysteine, which you nicely recounted as a risk factor. But it is kind of fascinating when you tackle these patients. I think there's a certain dignity and simplicity. I admire the great detail that you had today, and it's wonderful to kind of review all those mechanisms. What I usually do with the patients is try to get them to focus on to me, what is the molecule that is at the formation of this disease, which is a lack of nitric oxide. Mm-hmm. And once I can get patients to understand what are the foods that every time they ingest, they further destroy, their lack of nitric oxide, which has given them this disease in the first place, because that seems to trigger all these pathogenic mechanisms that you so nicely reviewed. And I often get one chance to see these patients because they're coming from somewhere throughout Canada, throughout the United States, and what have you, and they can only come to Cleveland for one visit. And so I usually do this in a group of 10 or 12 who we have a very, I think, generous notebook for them all, and that contains all of the slides that I'm going to be discussing. And they are going to get an absolute full dose of what it is that they have done to create their disease. Namely, every time they have ingested animal protein, oil, dairy products, and sugar, they have further injured the endothelial capacity to make nitric oxide, which is the great salvation and protector of all of their blood vessels. Mm. And somehow, when you give these patients 6 hours, which is the length of our session, there's enough glue in there because I must confess, I recount at least 5 or 6 times so that they absolutely walk away knowing fully and have a great understanding of the association of nitric oxide and the lack of it and the creation of their illness. So they really feel sort of empowered that they themselves now are able to actually be the controllers of their disease and have the power to eliminate it, and often get significant regression. Stop. All right, I'm going to shut up. But anyway, it's nice to see some familiar faces and to meet you and say hi to Mike and say hi to Scott.
Well, thank you so much, and I absolutely agree that how powerful nitric oxide can be. And there's quite a bit of literature out there, the interactions with homocysteine and how it can further inhibit nitric oxide release in the endothelium. So thank you for your contribution, again, your attendance.
Thank you.
Hi, Richard. This is Scott Stoll. I just wanted to say first, congratulations on an outstanding lecture. I can see that you're going to be a great leader in this field in the future, and I want to encourage you toward that end. One personal question. I don't think I heard, or I might have missed, your residency that you're going to be going into following medical school.
I'll be going for family medicine at the University of Utah in Salt Lake City.
Excellent. That's great. Congratulations.
Thank you much.
And then my question was, just in your review of the research, did you find any association between high-level, like ultra-endurance athletes, and atherosclerosis? I know there's some literature that describes neurodegenerative disease and cancer in ultra high-endurance athletes because of the high level of oxidative stress on their bodies. So that's the first question. And then second, did you find any literature, I haven't been able to find it, that would document a reduction in that oxidative stress level in those ultra-endurance athletes with a higher total antioxidant capacity diet?
So interestingly enough, I'm going to actually answer them in the reverse order. Because interestingly enough, I just pulled up a paper earlier this morning that I haven't gotten a chance to fully read yet that saw exactly that it didn't look at extremely high level endurance athletes. It looked at just marathon runners who they had those eating. They looked at dietary logs the week before a marathon and found those who had higher intakes of plant foods and fiber actually showed lower inflammatory markers after their marathon directly after and a day after their marathon than those who ate more pro-inflammatory foods that ate more animal proteins, meat and dairy. So it's a paper I really wanted to get into and look at, but yes. So there is some research now out there showing that these plant-based and anti-inflammatory diets really do help out, as we kind of knew and expected, endurance athletes who are going under large loads of oxidative stress. As far as your first question, then I am aware of literature out there on ultra endurance athletes and some risk of cardiovascular disease and events. I did not recently go through the literature and see all that's there. I know it seems to happen on people running really elite levels of miles or hours that they're training and just undergoing so much stress in their body that you really don't have the time to then heal from. And again, when it comes down to like the benefits of exercise are not just when you're actually exercising, but it's allowing your body to then recuperate and recover and strengthen itself after those inciting events of acute stress. So it is something I'll need to go back through again and try to look and see what is there. But from my understanding of what has been, it is really such a high level where you're just throwing off the balance of the time to recover and gain the benefits that you did from the oxidative stress you underwent during the exercise. But thank you so much for both of those questions.
Yeah, thank you so much. I always tell my patients, you're never going to outrun the effects of a bad diet, too. I have a lot of high-level athletes that will try to, eat poorly and exercise, extra to burn off the calories, but never outrun the detriments of a bad diet. So thank you very much, Richard. Well done. Well done.
Thank you so much, Dr. Stoll. And I agree. It's a conversation I have all too often with friends and colleagues, especially as we are now aging up a little bit. I think it's definitely a mindset when you're in your teens and 20s that, oh, it doesn't matter what I eat. It doesn't affect me now, and I'm active. But I think definitely as you age, you even see it come on more and more that the people who did not care to see what was on their plate or how much was there is now starting to add up for them for sure. Does look like another question was sent in on the chat. How would sulfur-containing plant-based diet increase or decrease homocysteine levels? So that's again where we see, from what I was reading, there is a lot of, I would even say confusion right now of what all the homocysteine means, and levels of homocysteine and where the homocysteine is coming from. Because there is some high-level methionine-containing plant foods, and even higher-level homocysteine can actually be elevated from a number of like plant diets as well. And that's where they're still trying to understand the true role of the dietary homocysteine we're getting, what high levels of homocysteine mean. Is the association with cardiovascular and atherosclerosis, is the homocysteine causing that damage first? Is it coming around second? So I don't know I have the answer of how exactly this sulfur-containing plant-based diet decrease homocysteine levels, because I think it's a little bit more complicated in what that all then means. But what it does seem, and please, any physicians and clinicians with greater experience than me, that patients on high-level plant-based diets who are physically active seem to avoid those chronic high levels of homocysteine that we find damaging and find as risk factors for cardiovascular disease. Are there any other questions out there? Well, thank you everyone for tuning in. I really do appreciate it. I appreciate all your questions and your support in all of this. And thank you again to Ethos Primary Care, to Gwen and Asha for helping out for Dr. Weiss and all he's done. And I want to make sure I'll give Dr. Weiss the final word here for bringing everyone together and making this event happen.
Well, I just want to say, I didn't think it was possible, but this is the second time I'm hearing this presentation, and it's more fabulous than even the first time. And that's why we asked you to give it, because you're a superstar and, in many ways. And we're so proud that you rotated through our practice in this farm, and that you are now with this presentation entering world as a brand new minted physician, and we're filled with high expectations regarding what you will bring to this world. And we can't wait. So with that, I'd like to thank everyone who came out today to participate and to listen to Rich. And want to thank Gwen and Asha for making this all happen. And thank you.
Thank you, Ron. Richard, you got a bright future ahead of you. We wish you all the best. Looking forward to seeing more of you. All the best.
Presentation.
Thank you so much, Dr. Klaper.
Outstanding presentation, Dr. Esselstyn. And I would wanted to say, I couldn't agree more. It's so nice to see the people like yourself in this young generation absolutely filled with the enthusiasm, inquisitiveness, knowledge, and energy to really take this to the next level. Excellent job.
Oh, we wouldn't be here without you and some of the other really pioneers of this field. So we're eternally grateful for that.
And thank you, Ron and Ethos team and Gwen. It's been an honor to be here. And Richard, your generation is the future. And so congratulations. And I really foresee that you're going to be a leader in the field in the future. So it's been an honor. Well done.
Thank you. May we all may we all be safe and sound and keep eating those plants and exercise.
Yeah.
Thank you very much.
Thank you.
Thanks, everybody. Rich, awesome job.
Great. Thank you so much.
Thank you, Megan.
You want to write an email to Ron because you didn't mention him.
Yeah. Yeah. All right.